At the outset, I
Thank
would
you
like to
very
thank
much.
Dr.
Thank you.
Paritosh for the opportunity to be in this interesting instruction course. There will be, unfortunately, some amount of overlap between the talks because the topic is such. So first, about origin of PVR, you were already introduced to by in the introductory comments of Dr. Paritosh. But I thought we'll make it a little more elaborate in the sense that the contribution for the origin of PVR is not just the retinal pigment epithelial cells, but even the process of vitreoskisis, or the so-called anomalous vitreous detachment, leaves behind vitreocortical remnants, which can also result in PVR process. The RPE cells and the epithelial mesenchymal transition, and also the spindle cell proliferation, leading to collagen formation, has already been discussed. And BRB is a very important part of the overall pathogenesis, wherein you get factors which are blood derived, not retina derived. They are cytokines and inflammatory cells. How do I move these slides?
Slide name more.
Yeah, okay. So then I'll just say next slide as well. All right, okay. So can you go back one slide, please?
No, so I think you can move it back.
Yeah. So there are also other cells which are not as evident in the literature and in our knowledge. They are the hyelocytes and Mueller cells. Hyelocytes, the concept is that there are cells in the anterior hyaloid which can actually recruit retinal pigment epithelial cells. In fact, their role has been not known very well until recently, and they have been shown to be important not only in the development of retina itself embryologically, but also in the development of PVR. So they recruit RPE cells. They also recruit glial cells and monocytes, and actually can be responsible for PVR. And they can actually transdifferentiate into the alpha smooth muscle actin positive cells, which contract and cause the fibrosis. Mueller cells can also be insulted by the ischemia that is occurring because of the retinal detachment. And this prolonged ischemia leads to Mueller cell hyperplasia and gliosis. That's what leads to the intraretinal gliosis, which is characteristic of a chronic PVR process. The proliferation of fibrosis, we all know where the fibrosis can occur. It can occur in front, it can be behind, as well as within the retinal tissue itself. I won't go into the details of that. Can I have the next slide, please? All right. Now, what are the risk factors? These are all what we need to know so that we can know, can we modulate the risk factors? Before the detachment itself has occurred, we know there are certain factors which make the eye predisposed for PVR if and when it develops detachment of retina. That is an injured eye, where especially a penetrating injury leads to a lot more disruption of the layers of the eye, including the choroid and the uveal tissue, that makes it more prone for retinal detachment, even before the detachment has occurred for PVR. Previous inflammation, if you operate on a uveitic eye, which has developed retinal detachment, the risk of PVR is increased. Aphakic eye in general is said to increase the risk of PVR, although exact reason is not clear. Systemic conditions have been already alluded to by Dr. Karobi Lagri in her presentation, and smokers have also been alluded to by Dr. Paritosh Kamtar. Exactly the relationship between smoking and this is not known, and I'm not sure whether stopping smoking a day before our retinal detachment has occurred can really influence the PVR. Next slide, please. But we all know more about the factors which come along with detachment of retina. These are large breaks, giant retinal tear especially. So larger the break, more the access of the RPE cells to the vitreous cavity. So more the cells liberated, they can easily cross the threshold required for PVR process. Presence of vitreous hemorrhage with retinal detachment again increases the risk because more blood in the vitreous cavity, more access of the blood-related factors into the vitreous cavity, the cytokines. Presence of choroidal detachment is an indicator of the inflammation in the eye as triggered by the retinal detachment, and that can again be an important factor. Also has shown are more than 2 quadrants of detachment of retina, and presence obviously of a detachment for a long enough time can lead to more scarring process. Next slide, please. But during surgery, there are also factors like excessive cryopexy. In general, we shifted away from cryo to laser, especially when you're doing vitreoretinal surgery. But if you're doing a scleral buckle and you're freezing the entire retina all over the place because there are multiple lattice patches, you increase the risk of PVR. And especially somebody who is a novice surgeon, will tend to freeze the eye much more than an experienced surgeon. So it always is important to know titrate how much you can freeze without increasing the risk of PVR. Subretinal hemorrhage, when it occurs as a complication of subretinal fluid drainage or a retinal incarceration, can also increase the risk of PVR. Next slide, please. Post-surgery, the role of inflammation has been already alluded to by Dr. Ramandeep. Significant and prolonged inflammation can cause risk of PVR. Post-operative choroidal detachment, even if it has not been there pre-op, can also increase the risk of PVR. But again, I think the one factor which you and I, all of us, can influence is an unsuccessful surgery. A primary surgery which is a failure, not because of PVR but due to other reasons, could be an important reason for risk of PVR, and that could be really influenced by all of us. Next slide, please. So what are the factors that could modulate? One, surgery as soon as possible. Again, this was stressed by Dr. Ramandeep, that even a 1 to 2 days of delay in eyes with giant tear, large tears, and high myopia can lead to significant inflammation, cause choroidal detachment, and you are forced to postpone the surgery all because you postponed it by 1 day. Now you want to treat the choroidal detachment and then operate. So you increase the risk of PVR. So if you find a GRT, please take it as an emergency, even if it is a Saturday night or a Sunday morning. But if delay is unavoidable due to other reasons, systemic factors, for example, patient is not fit for surgery, then at least start them on topical steroids and atropine before you contemplate surgery. Very often this is missed and the patient comes back to you with untreated with steroids, at least by topical medication. Next slide, please. Next slide. Yeah. Now, when eyes with retinal detachment coming with the choroidal detachment, we know are an important risk factor for PVR. There is a role of preoperative steroids, and this has been stressed by multiple studies, even randomized controlled trials. Using oral steroids, Dr. Sharma et al. Have shown that after one surgery with preoperative steroids, the success rate is 81.8% versus 66.7% if we did not give steroids pre-op. With intravitreal steroids, people have shown in this study by Juan et al. Of 13 eyes that the choroidal detachment disappeared in about 10 days after giving intravitreal triamcinolone, and there's 100% surgical success. By suprachoroidal steroid also similarly, success rate has been improved, but not as good as intravitreal steroids. You see the choroidals have disappeared only in 7 out of 10 cases, and there's a 90% surgical success. So intravitreal steroid should not be a problem, except that if you're concerned that in the presence of a choroidal detachment, your needle may not go in, you can still stick it in hard enough for it to be visible in the vitreous cavity if you're going to the ciliary body, which is not detached as much as the choroid. So I'm sure you'll be able to find the needle in the vitreous cavity and inject it. And if in the worst case, you have injected into the supraciliary space, which is probably not as good, but still good enough. Next slide, please. What about steroids as a prophylaxis against PVR, not as a treatment for choroidal detachment? In a meta-analysis, studies have shown that including oral intravitreal triamcinolone and intravitreal Ozurdex, there has not been much of a difference between with and without treatment. That is, there is no PVR pre-op, but you're trying to reduce the risk of PVR. It has not been shown to be of much prophylactic value. So, but in PVR, which is grade A and B, which is less easy to define, because what is B? At the most, vitreous haze from RB cells in the vitreous cavity, but no full thickness folds. That's probably there in a majority of vitreous surgeries you do for retinal detachment. So in those cases, it has been shown that oral steroids or preoperative steroids could be beneficial in reducing the postoperative risk of PVR. Now, if you include all the cases, there is no benefit. Next slide, please. But anti-proliferative agents is something that we try to concentrate upon now. The previous studies have shown that 5-fluorouracil with low molecular weight heparin infusion has been tried in 2 different studies. In one, it showed some reduction in PVR. In the other, it showed no advantage whatsoever. Daunorubicin has been tried in the past with mixed results, but none of them reached the primary objective, which is reducing the number of resurgeries. Colchicine and retinoids have been not found to be useful, and anti-growth factor, that is anti-VEGFs, have been tried with no response. Next slide, please. So we concentrate on intravitreal methotrexate, which has shown some promise. Dr. Narendra Babu is going to probably share some of his studies. But there's one study of a review article by McAllister et al., which has shown that the intravitreal methotrexate has inhibitory effect on RP cell epithelial mesodermal transition. It neutralizes the glial elements and decreases the cells with the contractile properties. Side effects are very few, but the half-life is very short. In rabbit eyes, it has been shown to be only 7 hours. And we know that the PVR window is roughly about a month to 3 months post occurrence of retinal detachment. So you need to cover the eye for this month period to be able to have the success rate of reduction of PVR process. 100 to 400 micrograms is what is the dosage required. Is my time up already? I'm sorry.
You can continue.
Okay. But what I want to stress is that it's injected into silicon oil filled eye. The frequency injection of on the table is 1, and weekly every 2 months for 2 months, and again at the end of the 3rd month, total of 10 in one study. And that has shown significant reduction of risk of PVR. But an RCT with a single intraoperative injection had shown no efficacy at all. The alternative is to use intravitreal infusion during vitrectomy. Next slide, please. And then that probably reduces the risk. The other maneuvers are that a vitrectomy is preferred when there is multiple tears or a RD with choroidal detachment rather than a buccal, even if you have reduced the choroidal detachment by using steroids. That removes the vitreous gel with all the blood-related factors and hence reduce the risk of PVR. Avoiding cryopexy, we already referred to. Fresh RDs should not be allowed to go into PVR, operate as early as possible. And during vitrectomy, very often what you miss is a layer of RP cells which are stuck in the inferior retina. You try to mobilize them using a flute needle and try to scrape them, even if you want to use a scraper, Tano scraper, and remove those cells. They are not still PVR, no fibrosis, but leaving them behind can lead to PVR subsequently. So remove the cells which are settled inferiorly. Studies have shown that gravity does help in RP cells settling at 6 o'clock meridian. Study by Bert Glaser has shown in rabbits which were actually put on right side or left side or upside down, that depending upon the gravity, the RP cells tend to settle down. So oil versus gas, oil tends to limit the PVR to the inferior fundus, and in the presence of oil, the methotrexate actually may be even more beneficial because it tends to collect in the fluid filled space, and PVR is already also in the fluid filled space. Next slide, please. So in conclusion, PVR is an obviously complex disorder with multiple trigger factors. There may not be one final common pathway that you could actually target using maybe one of these antibodies. You may not be able to find it because the pathway may be different in different eyes. The prevention, mostly by common sense measures can succeed, but they cannot ensure success. Prevention by intravitreal methotrexate appears promising. So even if you don't want to use it for routine cases, use it in high-risk cases or with recurrent PVRs. Intravitreal infusion coupled with postoperative injection may reduce the number of postoperative injections needed. So during surgery, you infuse with methotrexate, and maybe you can reduce the number of injections, but this is still not finalized as to how many injections are required. Reducing the risk of recurrence at the primary surgery, not due to PVR but other reasons, could go a long way in reducing the risk of PVR. Thank you very much for your attention.
Thank you, sir, for a wonderful keynote address on measures to